So welcome everyone, and thank you so much for joining us for the second Rapid Rehousing Workshop of 2020. And the second Rapid Rehousing Workshop we're doing remotely on Zoom. We're really happy to have you all here. The topic for this workshop session is navigating behavioral health services, specifically in Santa Clara County. So the information that the presenters are going to be talking to you about, and anything that we talk about related to the Continuum of Care, is all pretty specific to Santa Clara County and the Santa Clara County COC. My name is Eli Hamilton. I'm with Home Base, and I have two teammates from Home Base, two co-facilitators today, Nicole and Byla, who are going to be helping to facilitate the training. Home Base is a nonprofit based in San Francisco, and we work with a bunch of homeless systems of care in different communities across the Bay Area, in California, and actually nationally, to do things like training, technical assistance for federal funding, facilitating meetings. And in Santa Clara County, you'll probably recognize this most from this annual free training series that we offer. You might also see us around facilitating meetings. We're also here for all of you over email and phone, just as support if you have questions, maybe about your federal funding, maybe about best practices. If you have any questions and you want to reach out and see if we can help, please feel free to do that at any time. So that's Home Base. I want to call out a couple trainings that we have coming up. So the third Rapid Rehousing Workshop is going to be in 2 weeks. And that workshop is going to be just a little bit shorter, and it's going to be really focused on locating clients that are referred to your rapid rehousing programs from coordinated assessment. We know that can be really challenging. We have some rapid rehousing client engagement experts who are going to be presenting that training, and hopefully we'll be able to give you some tips, both generally and hopefully specific to locating clients during the COVID-19 response. I also really want to highlight a training that we're hosting next week. I know a lot of you have already registered for this, but we'll be having a compassion fatigue and avoiding burnout training next week that I personally am really excited about, and I hope that many of you are able to attend that. We also have some non-home base expert presenters joining us, thank goodness, for this training. So we have Lauren Gavin from the Supportive Housing Division of Behavioral Health, and we have Hi, thanks, Lauren. And we have Banerjee from Substance Use Treatment Services Research and Measurement.
Hi.
Thank you. And we have Melina Garcia and Sarah Betancourt from the Office of Supportive Housing. Thanks for waving. And as I said, my colleagues Nicole and Byla, who will be helping to facilitate. So we can take a look at, I wanted to, I said I would get back to some tech notes real quick. We are recording this training, and we'll make the recording available on the COC website. As I said, the chat box won't be recorded. You are all muted, and we're going to ask that you stay muted. There are a few points in the training when we'll offer to unmute you if you want, or we may just unmute you. But to cut down on background noise, please leave your mics off. And if you need to be unmuted, we'll give you that opportunity, and we can handle that, just so we can control how many folks we have on audio at one time. We'll also have one about 5-minute break about halfway through. During that break, we ask that you don't sign out of the training completely. It'll be a timed 5-minute break. We'll be starting promptly, so we don't want you to miss anything because you're having to sign back in. And if you have questions at any point during the training about anything, feel free to just throw them in the chat box. Don't worry about them getting lost because I'm not paying attention. We have Byla, who will be completely focused on the chat box. So if you have questions, issues, comments, or responses, throw them in the chat box. If this is, if you're new to Zoom, as a lot of us were when we started doing everything, all these big meetings remotely, you can look for that control bar that I've put a screenshot up on this slide. And it has a bunch of useful icons. There's a chat icon. You click that, the chat box will pop up. There's a participants icon. If you click that, the participant list will pop up. That's where you can actually see whether or not you're muted. So, speaking of the chat box, I want to start with an icebreaker question because everybody loves icebreakers, right? I'm going to start with my favorite icebreaker question. You may have heard this from me before, but honestly, it never gets old. So, go ahead and type in the chat box, please. What is your favorite hot drink? I know it's summer, but it is never a bad time for hot drinks. So, go ahead and type in the chat box. Just tell us what your favorite hot drink is. And Bila will be your voice. As those responses come in, she'll read them out.
I'm going to do some voices here. So coffee, 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 green tea, coffee, hot cocoa, more coffees, white soy mocha, hot chocolate, more coffee. I'm sensing that people are wanting to be caffeinated at this moment.
Fantastic. Thank
Kentucky
you.
bourbon coffee on the weekend. Okay.
On the
Gotta
weekend.
have that PSL pumpkin spice latte, chai tea.
Very nice. Awesome. Thank you. Okay, so I know you know where the chat box is, and I know that you're down with hot drinks, so I have all the information that I need for now. Thank you. Let's go take a quick look at the agenda. I hope you all feel welcomed and introduced to us. We'll start with a quick overview of just the relationship between behavioral health and housing stability and some quick notes on the Santa Clara County COC that I will be presenting, but I will keep that brief. And then we'll jump into an overview of behavioral health services in Santa Clara County. This is going to be in two parts. Lauren is going to be talking about mental health services that are not substance use treatment services. And then Kakali will be talking about substance use treatment services. So it'll be a 5-minute break in between. And then we're going to have Sarah and Melina do a short skit for you all, and then take some questions, a Q&A, about talking to clients about behavioral health and really engaging with clients about what can be both a stigmatized and a scary and challenging subject to talk about. We're also going to end with a discussion. We're going to start the conversation in a minute about some of the challenges that you all identified when you registered. And then we're going to come back to that discussion at the end and have some peer sharing about resources and strategies that you all are already using. Our learning goals for this training are pretty simple. We want to give you more information than you already have about resources that are available and how to get clients connected to them. And then to start or continue the process of feeling more and more confident communicating with clients about behavioral health services. And we don't expect that after a 2-hour training, you're going to be able to go out in the world and feel like you're an expert, unless you already feel this way. We're not going to turn you into experts about having these conversations with clients, but we hope that this is something that will give you, one next step, something to think about as you grow in confidence communicating with clients about behavioral health and behavioral health services. Okay. So I want to talk briefly about the connection between housing and healthcare because it's very important and it's worth coming back to. I think this is something that you all are very aware of and is going to make a lot of sense to you, that being in housing supports health for human beings. It supports medical, physical health. It also definitely supports behavioral health. And conversely, and at the same time, healthcare and connection to healthcare of any kind supports housing stability. So when we talk about someone's housing needs and housing plan and housing stability, we're always talking about that person's health needs. And behavioral health needs in the community of people who are unhoused or formerly unhoused are often at the top of the list of priorities and also of barriers to housing stability. We know that being unhoused or being unstably housed, having that housing insecurity, can have a huge impact on someone's mental health. And we also know that people with existing behavioral health conditions are very vulnerable when unhoused or housing unstable to having those conditions become worse, because of just the pressures and the trauma of being unhoused, and also because it becomes more difficult to maintain that connection to supports and connection to health services. So you all, as you're working to house your clients, are providing a type of healthcare. And we know that you also need help. You also need other providers and other systems who are supporting your same clients. So it makes a lot of sense that we're bringing those two, that we as frequently as possible bring those two worlds together like we're doing right now. And then another thing that we know, and we know this because of data, we know this because of local data, we know this because of national data, and we know this because of what we hear from housing providers. We know that people with behavioral health conditions can and do remain housed without long-term subsidies. We know that rapid rehousing can be challenging both for providers and for clients because of the time-limited nature of the assistance. And it can seem daunting if someone has barriers related to their mental health, related to substance use, those barriers to housing. Those can seem really daunting in a 12-month or 24-month period of assistance. But people remain housed and have behavioral health conditions. We know that this is true. We know that this is true in every area of the country. And one of this is like income and employment growth. This is an area where we're calling on your clients and you to be problem solvers, particularly because for a lot of the clients that are referred to a rapid rehousing program, because of the limited access that we have to permanent supportive housing resources and to long-term subsidies like housing choice vouchers, rapid rehousing is really the client's best and most likely chance to maintain housing stability. I want to point to some continuum of care, some COC-wide policies and procedures, because that's just what people at Homebase do. We like to talk about policies and procedures, but I'll keep it quick. So the COC, or the Continuum of Care, which is essentially the community of providers here in Santa Clara County, has a set of policies and procedures called the Quality Assurance Standards. These quality assurance standards apply to certain federally funded programs and actually quite a few locally funded programs as policies and procedures that are directly sort of applicable to your programs. They're a requirement that you comply with those policy procedures. They're also a good standard and a good example and a good sort of set of expectations for any program that's operating within the county geographic area. And these quality assurance standards have a section on policy that's a policy for participant termination. And I call this out because one of the concerns that we hear providers talking about is when do I exit someone if the reasons that I think they should be exited from the program are related to their behavioral health. So this policy is actually pretty helpful for figuring that out. And I also hope that the training and the resources that we're going to be providing are helpful in that area. The policy goes over the role of you all, if you're a rapid rehousing case manager in the room, and of the Office of Supportive Housing in determining when it's time for a client to be exited from a program. What to do in the case of eviction proceedings by a landlord. Eviction does not always necessarily and does not usually mean a client should be exited from the program. And also due process for participants that are appealing their program termination. So one side of this is it's important to know what the policies and procedures are that apply to you, both at the community level and at the program level. But it's also really important to recognize that we have a policy and a procedure for exiting clients from a program, primarily to prevent those exits, right? Our role as a system is to keep people in a program that's going to be supportive to them. And it is important that programs are able to exit clients if clients' behavior is truly dangerous, and after, or if a client's behavior is not showing sort of persistent and not showing any signs of change, it can be important for a program to be able to exit a client. But that should only happen in the most severe cases, which means that we're relying on providers, on programs to make every effort to help clients to avoid that exit, to avoid jeopardizing their chance in this program. And part of that is making sure that clients have access to the health services that they need. So that's the end of my background, setting up the importance of this. If you're here, so you probably didn't need to hear that, but we like to provide some context. Now I'm gonna, in a minute, I'm gonna ask you all to participate in this. I want to hear from you all. So just a warning, get ready to get into that chat box. I'm going to go through some challenges that you all identified when you registered. We asked you to let us know what are challenges that you experience with your clients around behavioral health. This set on this slide is really challenges that seem to be related to access to resources. They seem to be related to the system and what is available in the system and how you navigate the system. So being able to find free behavioral health services, that's a challenge. Wait lists and other barriers to accessing care, just the time that you feel you have as a case manager working in rapid rehousing or in any other type of program. Specifically, and this is something that we hear a lot both from clients and from providers, is finding affirming, safe, but also affirming services for trans, non-binary, and gender non-conforming clients. We know that that is a challenge in this community right now. Just knowing where to refer in general and what resources might be appropriate for your client. And then specifically during the COVID-19 response, what resources are there that can be accessed remotely, and how to go about that. So looking at this set of challenges, I want to invite you to go in the chat box and let us know, do you have any strategies for this? What are you doing right now? If there's a challenge on here that you have strategies to address, go ahead and type that in the chat box. Okay, I'm not seeing any, and that's totally fine. Hopefully we'll be able to, some of the information in the presentation will help you with figuring out where to find behavioral health services for sure, knowing where to refer and how to do that. So this next set of challenges, and Nicole and Bila, can you confirm that updated, that it's now a new set of challenges?
The
Yes.
first bullet point is need for more training tools.
Perfect, great, we're going. So this set of challenges is about sort of generally grouped around things that you might encounter in your day-to-day, things that you feel you need enrichment and training around. So just generally more training and tools, knowing how to approach the topic, how to help a client recognize a behavioral health needs. Basically, how do you talk to clients about this very challenging and sensitive issue? How do you identify if a client may have behavioral health needs? What approaches do you take? There was a few people who brought up wanting to feel more comfortable responding to a crisis intervention around behavioral health. That isn't necessarily something that we'll get deep into in this training, but we do recognize that that's a need that we hear about a lot. Understanding and helping clients address the effects of trauma can be a huge thing. And having effective communication between you and a client, and that we heard about that from both directions, right? Clients struggling to communicate, sometimes because behavioral health is challenging to talk about, sometimes as a result of the impacts of their health conditions, and then knowing how to effectively communicate to a client. Does anybody? Yeah, I'm seeing it's true, especially for clients who are moving around, living outside.
Some suggestions we're seeing here are try empathy and understanding, attempting to
challenges that we've sort of loosely grouped around in a category of challenges for the client, challenges that the client is experiencing. So clients may have difficulty understanding important information, reading a lease. It's challenging that clients find it challenging to follow through, and that also makes it challenging for you. So clients losing focus or interest in the plan that they're working on. And then we all know that there are behaviors related to mental health conditions that could lead to a threat of eviction. In cases where the landlord is moving to evict or talking about evicting for behaviors that are connected to behavioral health, we want to call out our excellent legal services providers in the county, so the Law Foundation of Silicon Valley and other Bay Area Legal Aid, because in most cases where behaviors are related to behavioral health, well, every case, the landlord really needs to be engaging in a conversation around reasonable accommodations. That doesn't always prevent eviction, but it is always something that you and your client with legal services support can ask for. Behaviors that can just feel frightening and make relationship building difficult, that was something we heard a lot. And that's a little different from actions that are by the client that are actually threatening or dangerous. Both are important to keep track of and to respond to. We know that that can be really stressful and challenging for you as providers. Compassion fatigue and vicarious trauma training next week. And then just stigma, keeping clients from wanting to address this, wanting to talk about it, wanting to access services. So we will come back to this discussion of challenges once we've heard from our presenters and our experts about some of the resources and strategies that they have for you.
We have a couple more strategies that
awesome.
people have mentioned. Someone called out the HHP program, which provides comprehensive care management, including a care coordinator that would be able to help folks address all these issues. Someone suggested asking your clients if they're taking their medication. Someone stated, my team has shared that our clients are not having as much of a difficult time in SIP since they live in an isolated life already, so it's more difficult for us. Someone else stated, making sure clients know we are available during the weekends as well.
Yeah, awesome. Thank you all for sharing. That's helpful to hear from peers. Okay. So I'm going to transition now to Lauren Gavin, who is going to give an overview and talk about mental health services that are available in Santa Clara County, specifically mental health services that are outside of the substance use treatment realm.
Okay. Hi. Can you hear me okay? Or should I start my video?
We can hear you okay. Video is up to you.
Okay, sure. Why not? Start my video. Hi. Hi, everybody. My name is Lauren Gavin. I'm a licensed marriage family counselor, but also I'm a senior program manager with supportive services, and I manage the behavioral health programs for our permanent supportive housing. So I guess flip. So what I'm going to be talking about mainly is about services for people that have Medi-Cal or are unsponsored. I realize that probably some of your rapid rehousing clients probably could have like Kaiser or private insurance. Those each are accessed in different ways. Usually on their health card, there can be a special number to access behavioral health services for private insurance people. But in the specialty mental health services are programs for people who are, we could say SMI, serious mental illness. When clients are eligible for specialty mental health, that means they can, the provider can also provide and get reimbursed for case management and rehabilitation services. Rehabilitation services are things like helping them learn new coping skills, like maybe if they're, for example, if they're isolated, a rehab specialist can help them figure out the bus system and get on the bus and things like that that aren't maybe typically thought of as a mental health service, but anything that helps them achieve their mental health goals can get reimbursed with specialty mental health services. There's also a lower level of care called for people that maybe just need medication, and those are provided in some of our our county clinics that we call FQHCs, Federally Qualified Health Centers. And those mild and moderate are really part of their physical health benefit, so are not kind of considered part of the mental health system. So some people might be getting their psychotropics at Hope Clinic or at Narvaez, but technically that's not considered a specialty mental health service. We have a whole network of providers in the county that we call CBOs, community-based organizations, that we contract with to also provide some of these services. So next, yeah. So in the county, we mainly serve individuals with Medi-Cal benefits and also people that are unsponsored, meaning with no insurance at all. They can get services through the county sites. Most of our CBOs do not take the unsponsored clients. So we also have some services some services are set up for special populations, like we have some AB 109 funding that funds some criminal justice programs, and also housing. We have mental health services that are especially for like a permanent supportive housing people. Okay, so there's lots of levels of care. We have that mild, moderate level that I spoke of before. That's mainly med management and not therapy as much. Then we have what we call our outpatient specialty mental health, and outpatient means anything that's not like they're not sleeping there is outpatient. So outpatient can be just weekly or monthly outpatient visits at a clinic. It could be FSP, which is a more intensive service, primarily for people who have episodes of mental hospitalizations due to a mental illness. And then there's a new service called ACT, called Assertive Community Treatment, which is also a very intensive mental health outpatient services with lots of that rehab services and skill development I spoke of. There's also a few levels of residential care. There's skilled nursing facilities where people would live there, especially if they also have, that's for people with concurrent physical health issues. And then we have the IMDs, which Institute of Mental Disease, which are for people whose mental health issues make it hard for them to live independently. There's also, of course, acute psychiatric services. So we have our 24-hour EPS, emergency psych services, for people that are being evaluated for harm to themselves or others, are gravely disabled. And then we also have our Barbara Aarons Pavilion, where people can stabilize after being admitted to the hospital. So let's see. So these are important numbers. All case managers should keep this phone number in their phone. All services for Medi-Cal clients are accessed through the call center. There's the phone number, and that's also the phone number for mobile crisis. So if you're out in the community and your client is having what seems to be a mental health crisis, but maybe it's not to the level of hurting themselves or others, you would call that number, and mobile crisis can either help determine if they can come out and help de-escalate this the situation or not. We have 17 contractor agencies. They're all over the county, South County, North County as well. Since we are a county agency, we are required to be able to provide services in all threshold languages. So even if we don't have clinicians that speak a language, we can use language services to help translate. So that's not a barrier. We also try to do our best to use evidence-based practice and person-centered interventions. Most adults who are receiving the specialty mental health clinics do at least get a psychiatric evaluation, and probably their condition is to the level they may need some psychotropic medications. So that's an included service. Okay, we do have, also in the county, we do have some culturally specific services. We also have specialized services for people that are 60 years old and above. We do have specialty services for people that are in the 16 to 25-year-old range. And we also do have some LGBTQ specialized services, especially in the TAY level, or TAY system. We also have the mental health department does have some faith-based services, which sort of are services that are connected to a church or a temple or a mosque. So let's see. Again, 24/7 is the way you access these services are through the call center. When clients will need to call themselves, you can call for them, but the client needs to consent to services and needs to talk a little bit about what's going on. If, a pointer maybe is, it's when you're talking to a client, and Melina and Sarah will talk more about engaging a client, but one of the most typical manifestations of a mental health issue is changing in eating and sleeping. It's always a good idea to ask your clients, have you been sleeping? If they've lost their appetite, if they've gained weight, if they've lost weight, any of those. And that's a really good system to bring forth when people are screening, because our mental health affects our physical health. And then that becomes that's what makes it medically necessary. You need to treat the mental health in order for your body to be well. So when they're doing that symptom screening over the phone, we are required to offer an appointment within 10 working days. Now, if a client says, I can only see someone Friday after 5, for example, something like that, it might take longer. So they might offer an appointment on a Thursday at 3, but if the client can't make it, it might take longer. Hopefully you can feel free to tell me if there's questions. So there's usually if you have Medi-Cal, there's usually no charge for services. Some clients have what's called a share of cost plan, where because of their income level, and this would include their physical health, their mental health, everything, they kind of are required to chip in like $100 a month towards their share of cost. And then after the, let's say $100, then everything is no cost. But it's really important not to say, oh, you won't get a bill, because sometimes they will get a bill, and then you don't want to set your clients up for you don't want to tell them they won't get a bill when it is possible they might. I'm not saying that they might not have to pay for it, but sometimes they're required to at least send a bill. And remember, one important thing is clients must consent to treatment. That's why it's important that they need to call. The case managers can help facilitate it, but they need to want to engage in services. Okay, let's see. So this slide's about kind of supporting your client in treatment, and I think it's important to there is a stigma for a lot of people and a lot of different families about mental health services, and I think it's important that we all check in with ourselves if we ourselves have negative feelings. If you're not, if you think it's kind of rubbish, or I don't know, if you don't think that it's a valid service, well, then you're probably not going to recommend it or encourage your clients to get it. So I always, if your clients in services, it's a really good idea to get a release of information so that you can talk to the clinician, so you can make sure that your goals are in line with the clinician goals. All clients in specialty mental health, the clinicians are required to have a treatment plan. And for example, if the clinician is working on a treatment plan for the client to leave the house more to, because maybe they're afraid to go out of the house and they're working on getting the client out, and the case manager is saying, oh, that's okay, you can stay in the house, it doesn't matter. Then there's sort of a clash, and that's not helpful for the client. So get on the same page, and that goes with the next thing. We call it splitting behavior. That means when maybe you might be hearing from your client, oh, that therapist, all they do is blah, 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 and they're terrible, and they're not as good as you. And you kind of start having negative feelings toward the clinician. That is a kind of a red flag that they might be kind of trying to play you against each other, playing kind of good cop, bad cop. So it's really important for the client's benefit that all the professionals are on the same team, and that comes across to the client. Reminders of appointments, that's another something that's really beneficial that the case manager can do. And also, if you have that release of information, it's really a good idea for you to communicate with the clinician. I noticed my client, boy, he's gained 40 pounds, or my client really seems agitated, or I really notice if I talk to him in the morning, he's fine, but when I go over there in the afternoon, it seems like a hard time for him. Any sort of patterns you notice, that's really valuable information for the clinician. So I encourage you to be in good contact. So, let's see. And more important phone numbers for your phone, that's the Suicide and Crisis Hotline. That's the mobile crisis, which you notice is the same phone number as the call center. And we have something new. We have a new texting crisis line, which is down there in the red bubble. That's, you text renew to that number, and especially the younger people are more comfortable with text. They can get crisis connect with someone via text through that number. So I think that might be it. Are there any questions or?
Very helpful information, including the contact numbers.
And I wanted to, so we did have a question during the presentation. Will these slides be available? Yes, they will be available to you. We'll send them all out to all attendees along with the recording. And also at some point they'll be posted on the COC website. So you will get the slides.
We do have a couple of questions that just came in. Someone said, I'm sorry I missed the last part. Is texting an option available for anyone?
Yeah, the texting is more, but this texting is like a crisis. Like, so if it's a good resource to give clients this, if you're feeling sad, if you're depressed, or but yeah, that, you mean as far as, do you need, maybe you're meaning, you don't have to have Medi-Cal for the suicide and crisis line, if that's what you mean. And same with the mobile crisis, that's for anyone in Santa Clara County. The call center is for people with Medi-Cal or uninsured.
Someone said, great, thanks. And then someone else stated that I have used mobile crisis and they are amazing.
They are amazing.
Awesome. We did not get to Lauren's contact information slide, but she did provide our contact information, and it will be on the slide that we send out. And Kakali, I think we have the majority of people back. So go ahead and take it away.
Great, thank you, Eli. Good morning, everyone, and thank you for coming to this presentation. I hope it will be helpful to you. I'm Kakali Banerjee. I'm the Director of Research at Substance Use Treatment Services, but I'm here in my capacity as a member of the senior management team. And so I'm obviously here to tell you about our system and how it works. I've been with the department for 19 years, and I have seen it evolve into its present state. And I'll talk a little bit about that in my next slide, which is my setup slide. Okay, the subsystem of care is now something we call DMC-ODS. That stands for Drug Medi-Cal Organized Delivery System. And this is part of a major reform that was happening in the state of California to restructure substance use services in a way that is more accessible to clients who need services. So there are some things that may be useful as background information, and I'll go through that relatively quickly, just so you get a sense of what the system looks like and how and why we do certain things the way we do certain things. So all of the services are organized in a continuum of care. You saw that in Laurel's presentation as well. So we have different intensities of care. They're called modalities sometimes. So you may have something that goes from less intensive to a very intensive intervention. And it's based on the American Society of Addiction Medicine, which really has described this framework in a lot of detail, and the state has adopted that as a basis for structuring substance use services. So services in SUTs are provided by a combination of county as well as contract providers, mainly community-based organizations. And together, this constitutes the SUTS network. And all of our service standards, reimbursement, and other requirements are based on a contract with the state, the Department of Healthcare Services. So that basically is why we do certain things the way we do certain things. Next slide. Okay, this is a overview of sub-services. I'll start with outpatient. Our lowest level of service is outpatient services, and the level is called 1.0. That's for clients who have sort of mild to moderate substance use. But we do have 3 levels of outpatient: intensive outpatient, regular outpatient, intensive outpatient, and partial hospitalization. We have another new outpatient modality called recovery services, and this typically is something that clients would be admitted to after they finish treatment. We also provide residential services. We have currently 1 level of residential service, but we are planning to create higher levels of residential services for clients with medical comorbidities as well. SUTS offers withdrawal management. This is a short stay stabilization level of care. And typically, this is not considered treatment. It is something that the clients would enter, and then after their stabilization, they would be referred to another level of care where they would receive actual treatment. So withdrawal management is for stabilization for people who are using actively and need to detox. It's not medically managed. It's a social model detox. We also have the NTP-OTP program, which we also call addiction medicine therapy, treatment. And we offer a number of medication-assisted therapies in this particular modality. The methadone program is located here. We also have daily buprenorphine. and Vivitrol for those who qualify for that. So there is a medical evaluation that typically occurs before people are placed on any kind of medication. And there are some fairly strict rules around who can and cannot get on those medications. Another major service that SUTS offers is recovery residences. These are sober living environments that are available to clients who are in active treatment in an outpatient service. So they have to be in an outpatient service, such as outpatient, intensive outpatient, or partial hospitalization, in order to be eligible for placement in these sober living environments. Next slide, please. Okay, so let's talk a little bit about the eligibility criteria for entering into treatment in the SUTS system. I noticed that there was a question somebody had brought up about getting access to behavioral health and free or low-cost services. So the next few slides, I hope, will answer that particular question. So let's start with how does a client get into the SUTS system of care? There are actually three things, but Lauren reminded me that I needed to add the fourth thing as well, and so I'll talk about that. So for the first thing is that the clients must meet the diagnostic criteria for treatment. So they must have a diagnosis for some sort of substance use, whether it's meth or it could be cocaine, it could be heroin, and there are a few that have been that are eligible for Medi-Cal reimbursement. Okay, and so those are the ones we will typically use in order to move a client forward. Then they must also meet criteria for treatment within a SUTS level of care. We don't have every single modality that a client may need. For instance, if a client needs hospitalization for a particular condition, and for instance, if it's sort of a medical hospital-based withdrawal management, we would not have that service. We're trying to get a referral to a service like that, but currently we do not have that service. And they must be a resident of Santa Clara County. There are some exceptions, and I'll talk about that later. Primarily, these are folks who may be living in another county, but they're planning to move to Santa Clara County, and they are moving their Medi-Cal as well. So then we do permit them to come into our system. And of course, the most important thing is the clients must be willing to accept treatment. So they don't sign a consent to treatment. We can't really coerce them or put them in treatment. It is the client's choice. Next slide, please. Okay, so I'm going to go through this quickly, but I think it's important to understand why it is that someone who you think may have a substance use disorder is turned away. So the first thing, of course, is that they have to meet a DSM-5 diagnosis for a substance use disorder. And how does that happen? A diagnosis is established by a licensed clinician, and that clinician will conduct a clinical interview, a very detailed assessment to arrive at that diagnosis. And then the DSM diagnoses that are acceptable, as I mentioned before, must fall into these categories that we treat. For instance, SUTS, we don't treat tobacco-related diagnoses. We don't have a tobacco-related program. So if someone has that as their primary diagnosis, we would not be able to offer them that treatment. So we encounter this last point quite frequently, it is possible that someone who's using substances, even illicit substances, may not actually meet the diagnostic criteria for treatment. So we know this because we get many, many referrals from the criminal justice system, from probation officers and people in court who feel that the client may benefit from treatment, but if they don't meet the diagnostic criteria, they will not actually be admitted to treatment. Something to keep in mind. Next slide. Okay, so the second thing that is looked at when clients seek treatment in our system is that in addition to these, to the DSM diagnosis, they're also assessed on a six-dimensional scale, there's a six-dimensional assessment based on ASAM criteria, and they have to meet those criteria, and that's a whole separate way of looking at level of care placement. And then they have to meet those criteria, and then once they have met the criteria, then a proper placement can be made for them. And then there are specific criteria for residential services. So a client might feel that they need to be in a residential service, but unless they meet the criteria, the ASAM criteria for placement in that level of care, that will not be a recommendation for them. Okay, and all residential services requests are reviewed and authorized by such quality improvement. Next slide. Okay. Now, this is an issue that comes up quite frequently in many, many venues. So I hope that this slide clears up some of the misconceptions that may be out there about paying for services and immigration status. Santa Clara County is actually a very generous provider of substance use services. A large number of our clients historically were unsponsored because Drug Medi-Cal didn't actually pay for very many services or very many people. It's a little bit different now because of ACA, so we have more people who are eligible for Drug Medi-Cal services than before ACA, so that's a good thing. And so let me start with the insurances that insurances that we accept. So we accept, of course, Drug Medi-Cal, Valley Health Plan, Santa Clara Family Plan Medi-Cal, Anthem Medi-Cal, and we have, and of course, we take uninsured clients who meet the diagnostic criteria, okay? Any other insurance, if they have other insurance that is not covered, and then again, these are all Medi-Cal plans. So that if clients have other insurance, they will typically need a denial letter from their insurance company before they can be placed in treatment, because their provider does not, their insurance company does not have a contract with us. Okay. So county funds are used to pay for a lot of services that Medi-Cal doesn't reimburse. And for instance, clients are often placed in recovery residences. That's not reimbursed by Medi-Cal, it's county dollars. But nevertheless, we do provide that to anyone who needs to be in a sober living environment. The typical payment is usually on a sliding scale and is based on an ability to pay. And I think Lauren alluded to this earlier, that there might be a few people, even if they are unsponsored, there is some sort of an assessment about ability to pay. And it's generally done on a sliding scale. And if the client is unable to pay, then that's not a barrier to not receiving services. Although they might get a bill from the county because PBS that's patient billing services, will automatically bill somebody for a service. And we don't turn anyone away for their immigration status. That is not an issue. We do not ask those questions. And the primary criteria is really for the system is the diagnosis and the ASAM placement criteria. Next slide. Okay. What happens when a client calls Gateway? So does everyone know what Gateway is? Gateway is the substance use call center. And I'm sorry, I forgot to put the Gateway number on this, but I do have a way out in the last slide, which I'll explain when I get there. So Gateway is primarily a screening and referral service. It is our telephone portal. The majority of our clients get into treatment through that Gateway referral. And what typically will happen is when the client calls, there is a brief screen that basically establishes whether the client needs substance use treatment at all. And it's a pretty generous screen. Most people who call will get through the screen and be referred to a provider. The actual assessment will happen at the provider level. So once Gateway refers, Gateway has no further role. That's because their job is ended at that point. Okay, that's an important thing to keep in mind. Gateway doesn't decide who gets admitted or not. They are simply a screening and referral division within our services. Next slide, please. So what happens when a client arrives at one of our major modalities? For our addiction medicine, NTP-OTP, which by the way stands for Narcotic Treatment Program, Opioid Treatment Program, these are old-fashioned terms, which is why we have acronyms. Generally, clients receive an appointment for a intake, and some clients do walk in, but that involves a very lengthy wait because there is a medical evaluation that's quite extensive, that's required by law. And so it can be a very lengthy process before the first dose is even administered. Outpatient providers in our system, we have a number of them. They have both open access days when a client can just walk in after with a Gateway referral, or it's by appointment. So they have certain time certain that they will give to a client. It depends on the provider. For residential treatment, typically Gateway will then send that particular referral to the residential placement unit, which is located in the quality improvement department. And there's a placement coordinator who coordinates the placement of clients into a residential bed. Right now, we don't have a wait list, and it should be relatively quick to get a placement into a residential bed if the client is eligible for it. Detoxification services are called withdrawal management now. They're open 24/7. Unfortunately, it's a very small modality, and the beds are usually occupied, so clients need to call every 2 hours until a vacant bed is found. We're trying to change that process because it's very burdensome on the clients, but nevertheless, that's how it is working currently. Next slide, please. Okay, so what happens when a client gets to a treatment provider? If the admission criteria are met, so this is the scenario. The client arrives at the provider, they get an assessment, okay, by a clinician. And at that point, a determination is made as to whether they meet medical necessity for treatment, they have the right diagnosis, and they have a level of care in which they can be placed. And so let's say a client is referred to outpatient, there's a clinical assessment, they meet the criteria, then the admission criteria met and the client is admitted on the very same day. Some providers have lengthier intake processes, others not have shorter ones, but the process is more or less the same. It just takes different amounts of time for some reason. Next slide, please. Okay. So what happens when the admission criteria for the referred level of care is not met? One of these three things will happen to the client. The client may need a different type of treatment. For instance, they are referred for outpatient, but the clinician determines that they need residential. And at that point, that provider is obligated to refer the client to the residential level of care. And there is a conversation with the quality improvement department, and because QI needs to authorize that. And then they are moved to a residential level of care, let's say. But what happens if a client does not have a diagnosis for a substance use disorder? Then a client is referred to another service outside the department. Then the last one is not that the client doesn't actually meet the criteria, the client just doesn't show up. 3 attempts are made, and then if the client doesn't show up within that 30-day period, a gateway referral, by the way, is just good for 30 days, okay? And so the client must show up during that time. And if that client doesn't, then there is no further action. Next slide, please. Okay, so I am going to, I think in the interest of time, I'm going to just say what I'm going to say about this slide is, this just gives you a sense of how long how intense the service is, and you can kind of read this on your own. Outpatient services are the least intensive. Partial hospitalization is the most intensive outpatient service, 20+ hours a week. It's very hard for clients to do. Withdrawal management stays at 3 to 7 days. Medication-assisted treatment like methadone can last for years. And residential services, generally clients stay for 30 to 45 days. Next slide, please. Okay, great. All right, thank you very much. All right, I'm sorry, I feel like I'm rushing through this, but I'm hoping we'll have a few minutes for questions at the end. This is a lot of new information, my thinking was more information is better than less, but maybe I'm wrong on that. So what are the barriers that clients typically face in getting the most out of substance use treatment services? One of the major things that we've seen, and I know this because I've studied it as well as having encountered it in a management situation, is non-attendance in treatment. And there are lots of reasons for it, but transportation barriers are very important. Inconvenient clinic times. For women, it's childcare issues. For some of our clients who do work part-time, there are schedule conflicts. Often our clients forget appointments. Some of them are homeless or unstably housed, and which is why it's very, very important for them to be housed. Many clinics are now offering telehealth options, but what we found is many clients don't have access to reliable internet services. So it's very difficult for them to use that service. Homelessness is a very major issue. We have homeless clients who cycle through our system, and homelessness is such a stressful situation. It's hard for them to focus on treatment, frankly, and it's totally understandable why that would be. But one of the other issues is sometimes the clients and counselors do not actually develop that therapeutic alliance that is so critical to success, and we see that in ways that such as early dropout from certain programs very consistently, because the clients then tell us in exit interviews, if they fill out that form, that they didn't kind of connect with their counselors. But that's not something that we studied a lot, but it does happen. Next slide, please. Okay, how can case managers support their clients? There's a lot that case managers can do. They can connect clients to all of the other services that they need. Many of our substance use clients actually have multiple needs. They have legal issues, they have homelessness issues, they may have comorbid medical conditions, they may have domestic violence issues. There are a whole host of things that are not necessarily all something that a counselor can handle on his or her own. So there are all these other surrounding issues where a good case management team can provide vital support for these clients. The other thing is reminders about appointments is very important. Often clients don't remember because they don't have places where they can write things down. They don't have computers, or even if they do, they may not be able to keep them in a place where it's usable. Transportation support is very important. We know that because we give out lots and lots of bus tokens. That really does help clients attend treatment regularly. And help with cell phones and computers to connect with providers, we've realized that has become such an important part of keeping, of maintaining that connection with the programs, with the counselors, that anything that can be done to provide them with that access be extremely beneficial in continuing treatment during a challenging time like this COVID quarantine. Okay, so I think I'm on the last slide, the last one. Okay, so you can always email me, but I have the website, and the website has a lot of information. It has the call center number, it has many manuals, it has a provider site and a client site, so there's a lot of stuff that can be, a lot of information there. So let me just stop there and see if people have questions.
It is, I understand detox treatment is very challenging, and when people get out, they're more vulnerable to, I think, overdose, OD, or relapse. Are there statistics to show that it's effective and cost-effective than a longer-term solution?
In the subsystem, the detox is not considered treatment. In our system, it is expected and the standard policy that anyone entering detox must be referred to another level of care. So no, detox is not an effective treatment in and of itself. It's simply stabilization, and continued treatment is absolutely essential. So there's a lot of literature about why people don't continue on, because we have a lot of attrition between withdrawal management and other levels of care, and there are many reasons for it. So all I can say at this point is case managers can be very helpful in negotiating that transition to substance use treatment from withdrawal management.
Not seeing anything in the chat box, but I want to give you the benefit of the doubt if you have a really in-depth question and you're typing frantically away and don't want to miss your chance, give you a little bit more time. Okay. Okay. Well, it doesn't look like we're getting in any other questions for Kakali, so thank you so much for that great presentation. It was very thorough and clear, it seems.
Thank you very much for listening to me. I'm sorry I went over. I didn't realize the slides were I didn't realize I had so many slides. So.
There was a breakout group and discussion component of this training that has been removed for the recorded version, but I do want to make sure that everybody knows how they can contact us at home base if they have any questions or suggestions for training topics, or questions about federal funding, or ideas about ways that we might help you. I'd also want to thank the County Office of Supportive Housing, who is our partner putting on these trainings we work with to support you all in Santa Clara County. And I also very much want to thank our 4 expert presenters. They had really great information, and we really appreciate them volunteering their time to do this for our providers. And then finally, I want to thank everybody who attended the training and everybody who is working with our unhoused and formerly unhoused and people at risk of homelessness in Santa Clara County, particularly right now, but all, as you do your work, we very much value that. And so thank you so much for everything that you do. And I hope that everybody has a good